I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hi, everybody, and welcome to the July edition of Plastic and Reconstructive Surgery podcast. I'm Sammy Sinno, and joined as always by my co-resident ambassadors to the journal, Amanda Silva from University of Chicago and Raj Sawh-Martinez from Yale. This month, we're very happy to be joined by our special guest moderator, Dr. Babak Mehrara. Dr. Mehrara is a true surgeon scientist. He is a plastic and reconstructive surgeon at Memorial Sloan Kettering Cancer Center, and he also runs one of the most important and influential labs in plastic surgery, doing a lot of groundbreaking research in lymphedema. Dr. Mehrara, thank you so much for joining us this month.
Sure, my pleasure.
We have three great articles that we're going to discuss. The first is by Drs. Surek, Vargo, and Lamb, and it's called The Deep Pyriform Space, Anatomical Clarifications and Clinical Implications. In this study, the authors sought out to further define the clinical implications of what's been historically called Risto space. This term was utilized first in the original Pessa and Rourke article defining the fat compartments of the face, and is named after Dr. Bruno Risto. The authors dissected 12 hemifacial fresh cadavers, and they did 3 different group dissections. In one group, they made plaster moles to evaluate the shape and contour of the region. In the second group, they percutaneously injected hyaluronic acid, and they wanted to see what structures were adjacent to this area. And finally, they pneumatized the area to determine the cephalic extension of the deep pyriform space. What they noted was that the space, on average, was approximately 1.9 centimeters in dimension, and also, importantly, was bounded by the depressor septi nasi and laterally by the deep medial cheek fat, which is an important fat compartment in facial rejuvenation. They also noted that the angular artery coursed down the roof of the space, which is an important anatomical consideration for safe injection into this area. The pneumatized specimens showed that the space traveled cephalic to the level of the tear trough ligament, and the authors postulated that this may be responsible, this area, for some edema that occurs when performing procedures in this area. In review of the article's main findings, they defined this space as a critical landmark for rejuvenation in facial aesthetics, and noting that with age, as the malar bone typically recesses, this area becomes more prominent and would be even a bigger target for facial rejuvenation. Again, further clarity will help determine its role in potentially regulating malar edema, but at least for the time being, I think the authors have done a very careful job of defining the anatomy, defining the safety of injection into this area with respect to the angular artery, and then also delineating average volumes that could be potentially useful for injection into this area. So, Dr. Mehrara, in general, what do you think about this very interesting cadaver study?
Well, I think they did a really beautiful job of looking at all the space in a very systematic way. The pictures in the manuscript are really beautifully done, the anatomic dissections that they did. And I think, we really need to be able to do stuff like this to understand the anatomy of a place to make the really big changes if we want to. Now, this is a very small space. You said it's 1 by 1 or 1 by 2 centimeters, but if you look at it, it's really the junction of the important angles of the face. So I think it's important anatomic knowledge. The finding of the angular artery, I think that's interesting, but to me, the rest of the study was actually much more insightful, because I think it's unlikely that you're going to stick the angular artery with an injection, but everything else was great.
Yeah, I think the other interesting component and they sort of mentioned this in the discussion, the potential role of this space regulating lymphatics. I know that in seeing, a lot of surgeons that primarily do facial aesthetic surgery, they oftentimes will say how troubling malar edema is, and if you get it, how difficult and distressing it is for both the patient and the surgeon. And I don't think we quite know exactly how and when you're going to to get malar edema. I think it's related likely to the lymphatic drainage of the infraorbital area, as the authors point out. But maybe this space does have a certain role in awareness of that potential complication. May be related to certain procedures that traverse or come close to the area of dissection. I don't know. What do you think about that? Maybe from a lymphedema perspective, in terms of malar edema and maybe things that could cause it, or how maybe this article fits into that discussion.
Well, I think that's an interesting point. The lymphatic vessels of the face, as with everywhere else, run along the major vessels, so they would probably run along the angular artery and vein that you see. The other interesting thing about the lymphatics is that they really have an interesting relationship with fat. For a lymphatic vessel to be healthy, it needs to have a healthy layer of fat around it. That fat can't be inflamed because that makes the vessel unhealthy. And so you can imagine that if this fat pad atrophies in an older patient, then the lymphatic vessels in that area would probably not function very well, or also atrophy as well. And it'll be actually interesting to see if that happens.
Yeah, that'd be interesting to see also if it is related, if you would maybe prefer to fill with fat versus a filler, or a filler would have, more of a scarring effect and affect the lymphatics in a negative way versus injecting fat and restoring that healthy bed.
Or if the lymphatics actually regenerate after you inject the fat. Who knows?
Yeah.
Infraorbital edema is a big problem in reconstruction as well as aesthetic surgery. So, even just a small incision below the eyelid will result in edema for a very long time. So that may just be a watershed area. And then that may be compounded by the fact that this fat may become atrophied and also take with it the lymphatics.
Mm-hmm.
Yeah. Mm-hmm. These are awesome points. And actually, that's exactly what I was sort of in my thought process too, man, is what you were sort of mentioning. I wonder, because would replacing the fat that is deflated over time, is that going to be, result in better long-term results? People talk about the fact that, with fat, you don't potentially have as much control over what the results are going to be, but, there's so many secondary things, including the, potential healing of lymphatics, or, that may be improved in the long term as these studies sort of continue to come out. And then the other thought that I had, I wondered, I think these cadavers, Sammy, would you mind reminding us, the ages of them, in the sense that, would the anatomy, or how does the anatomy vary, as they age? And I think those 12 cadavers, I think that they looked at, that you mentioned, but, what is the age distribution, right? Would this space be different in its dimensions and its anatomical relationships in, let's say, 30, 40-year-olds versus 60, 70-year-olds, and how would that relate to things as to when we're injecting fat or filler, or even in facelifts, and considerations in that regard?
Yeah, I think definitely great point, Raj. And bony recession, as they pointed out, of the maxilla with age leads to this space taking on its own character a little bit more prominently. So I think that would be interesting to see how that varied with age. I can tell you some of the cadaver facial dissections that I've done. There's a big difference with the fat compartments between the 40-year-old cadavers and the 70-year-old cadavers. So I think that would be an interesting question for the authors, for the journal club later on down the road. Any other thoughts on this article before we move to the next?
No, it was nice.
No, great discussion.
Yeah, great discussion. Thank you very much, Dr. Mehrara.